Welcome everyone who's joining us today. My name is Minsu Lee, and I am Director of Business Development at Soundable Health. Today's session is a series of webinars from proudP, where we gather insights from renowned urologists to better understand men and women's health. Thank you for all of you for joining. And now I would like to start the session by introducing our speaker today. Dr. Jerry Blaivas is a professor of urology at the Icahn School of Medicine at Mount Sinai and a world-renowned expert in reconstructive surgery, voiding dysfunction, incontinence, neurogenic bladder, and urodynamics. A pioneer in many diagnostic and surgical procedures, he has been recognized as one of the forefathers of female pelvic medicine and reconstructive surgery and was honored as a legend in urology by the Canadian Journal of Urology. Dr. Blaivas has received numerous prestigious awards, including the Victor Politano Award from the AUA and the Lifetime Achievement Award from SUFU. He founded Urology and Urodynamics and served as editor-in-chief for over 2 decades. He has authored over 500 peer-reviewed publications and 12 books, has lectured globally as a visiting professor, and has played a key role in shaping clinical guidelines for incontinence and BPH. Additionally, he is the founder of the Institute for Bladder and Prostate Research, dedicated to advancing knowledge in lower urinary tract disorders. Before I move on to sharing the floor with Dr. Jerry Blaivas, I would like to share also a little bit about Soundable Health. Soundable Health is the company behind today's webinar, and we are dedicated to advancing digital health solutions for bladder and prostate care through AI-driven technology. One of our flagship innovations, proudP, is the simplest way to perform Uroflowmetry in your office. Managing a busy practice requires solutions that enhance efficiency and patient care, and proudP, an AI-powered Uroflowmetry replacement, delivers clinical-grade accuracy while streaming clinic operations. Now let's get properly started with the webinar. We encourage you to submit your questions through the Q&A feature at any time during the session. We'll reserve time towards the end to address as many of them as possible. Thank you. Now over to you, Dr. Jerry Blaivas.
Well, thank you for that kind introduction. And I'd also like to thank the whole proudP staff for allowing me to share my thoughts about this impactful new technology, remote Uroflow monitoring. I believe it's opening up brand new vistas for us for the diagnosis and treatment of men and women with lower urinary tract disorders. So here are my conflicts of interest that you can read, but I'd like right off the bat to get started. So here's 2 different urinary flow rates. On the left, you see typical of men with prostate disorders. And you can see, and the one on the left is a perfectly normal flow. It's over 15 milliliters per second, which is considered the cutoff for normal. And multiple areas of research have shown that if you have a normal flow rate like this, the odds of having underlying prostatic obstruction are no more than 1 or 2%. So you can be pretty confident when you see a flow like this that the patient does not have any kind of urethral, certainly does not have prostatic obstruction at least. The flow on the right shows a depressed, a low flow with a plateau shape. And that's typical of people with obstruction, men with obstruction, but there's lots of other things that cause it, including impaired detrusor contractility, urethral strictures, and most importantly, a low bladder volume when you start to void. So it's not in any way pathognomonic of obstruction. But you need to evaluate this. So these 2 patients would be treated and very differently, and their diagnostic pathways would be very different. Unfortunately, these are not 2 different patients. These are the same patient, and you can see by the date they're just 3 days apart. So if you did a flow on this day, you'd say he was normal, and if you did a flow 3 days later, you say he has probably has obstruction. So how do you explain these two different flow patterns in the same patient? I'm going to give you about 20 seconds to read this. We hope to make this live, and we would have done an audience response question, but we can't do that remotely. So we'll let you look and see what you think. Well, the answer is all of the above. Any of these things could have caused it. But that led to a hypothesis that we never would have had we didn't have remote Uroflow monitoring. Okay, so a single normal flow curve in a clinically obstructed, a single normal flow curve in a clinically obstructed patient suggests that the obstruction is due to failure of relaxation of the sphincter muscles, a functional obstruction, rather than a mechanical obstruction from a stricture or prostatic compression. And we hypothesized that, and also that a single normal flow curve would be a positive prognostic sign for successful treatment with medication or with even behavior modification. So wouldn't that be great if we could look at a flow curve, look at a series of flows and say, this patient will be good for surgery and that patient should respond to medications. We're not there yet, but I'm hopeful with the research that flows from these remote Uroflows will lead us in that direction. Just a little bit of history. The first published Uroflowmeter was in 1897 by a German by the name of Reifisch. And the important thing about that is he recorded voided volume as a function of time. So this is the curve that he got. And in order to derive a flow curve from that, you had to do calculus back in the 19th century with a pen and paper. And I imagine it took him longer it might have taken them longer to integrate this curve than it's taking me to give this talk. It certainly would take me longer than that. So the next important research that came along, or actually flowmeter that came along, took a half century, and that was the gravimetric flowmeter by Drake in 1948. And it used a very simple principle. You urinate into a receptacle. The receptacle pulls the lever of this arm down, and it records the increase in weight the increase in volume or weight on a chymograph. And that's exactly what Reifisch did, except for there was an interposed column of air. And then it took another half century. Seems like we make progress in Uroflows measured in half centuries, so far as I can see. It took another half century before someone, Kozo, was able to detect the sound and the vibrations from urine passing through the urethra. So they had a sensor right up against the urethra, and from that, after writing algorithms, they were able to get a flow curve from this sound or vibration pattern. They would write an algorithm to get rid of the extraneous noise, etc., and they got a very good flow curve. Today there are four main kinds of flow meters on the market, but gravimetric is by far the most common, and especially for the remote flow meters. And then I don't know where Sonoflows and the rest of these fit, but gravimetric is the most common Uroflow used, and we'll talk about that a little bit later. Next, I want to show you the setup that proudP used to validate their flowmeter, which is basically, they showed you an app. It's housed in an app on a phone that measures the force, the sound of the stream of urine hitting the water. And I thought this was really ingenious. They reconfigured a bathroom with a sensitive scale underneath, and then they recorded at the same exact time. They recorded flow through through the app and through the sound technique through the proudP, and at the same time the change in weight, which is a gravimetric method. So that was I thought that was a really ingenious way of doing it. And it turns out that proudP was the first commercially available sonoflowmeter. It was first marketed in Korea in 2017 under the brand name Privy, Privy, and then they subsequently changed the name and marketed it in the United States. But I want to point out what high correlation they found between voided volume, maximum flow rate, and average flow rate. Look at these correlation numbers between the gravimetric flow meter and the acoustic flow meter. Now, I want to do a little bit of history, not much, of what the role of flows were. So there were no commercially available flow meters prior to 1950. There were some that some people in academics used, but then in between 1950 and the 1980s, in what I call the pre-Marco Kane era, okay, virtually almost everybody thought that BPH, benign prostatic hypertrophy, was synonymous with BPO, benign prostatic obstruction. And the treatment algorithm was really very simple. It did a history, an exam, a urinalysis, some empiric treatments that mostly didn't work. And this is before the introduction of alpha blockers. And then if the patient failed, they underwent surgery. And there's only 3 kinds of surgery that were commonly done: suprapubic, retropubic, and transurethral surgery. But in this period, people in academics, and like myself, started to think of things differently, and we made a distinction between people that had normal flows and people that had low flows. So people with normal flows, we thought were not obstructed, and we'd go ahead and treat them with empiric methods. And people that had low flows would get treated starting in the late 70s and early 80s. We started using alpha blockers because Marco Kane's landmark paper and Shlomo Raz was the second author on that one, for those of you that know Shlomo. That paper showed that there were rich adrenergic fibers in the prostatic capsule, and they postulated that it was those fibers that contracted to cause obstruction in general, and in particular urinary retention. And it became quite clear to many of us at that time that alpha blockers were a reasonable treatment for people with obstruction if they had the kind of obstruction that was amenable to it, like my hypothesis said in the beginning. We haven't done that research yet, so we don't know if we'll be able to make that distinction. But we now have the tools to do so. So what about the present? Well, obviously, we know, most people know, that BPH is no longer considered to be synonymous with benign prostatic obstruction. It has a differential diagnosis, and there's multiple guidelines that exist for the diagnosis and the treatment of men with lower urinary tract symptoms. But Uroflow is the sine qua non of what I consider to be the 5 pillars for the initial evaluation of a myriad of conditions that cause lower urinary tract symptoms. What I'm about to show you does not follow the AUA guidelines. So for those of you that are still waiting to take your boards or something, you might want to close your eyes and ears for a moment, because it's not the initial thing you're supposed to do. But I call it, gave it an acronym, sub-QP, and it stands for symptom assessment, urinalysis, bother, flow, and residual urine. And that means that when I believe that we should do all of those things, including a flow and a residual, and residual urine, and also in most patients also do a diary and the questionnaire. I left out the diaries, but the AUA recommends the IPSS. I recommend others. Okay, now I mentioned that there's a differential diagnosis to men that have what some people used to call and still call prostatism. Other people call it BPH. Academics like myself call it lower urinary tract symptoms in men, but it all means that it's a man in the prostate age that we think the most likely diagnosis is prostatic obstruction, and multiple studies have shown that to be the case. So in men in that age group with prostatism or male LUTS, multiple studies have showed about 2/3 of those men actually do have prostatic obstruction, but about nearly half of them also have overactive bladder. Sometimes the obstructive symptoms dominate, sometimes the overactive bladder symptoms dominate. What's not widely known is that about a quarter of the men also have, a quarter of the men have polyuria. And I'll show you a case later where it was polyuria that was causing all the symptoms. Then it's up here. Excuse me, I'm blocked by something. Just want to, oh, you can see it, I can't. So this is the differential diagnosis. In a few studies, about 9% of people had low bladder compliance, which is also important to know, because of all the things we're talking about, that's the one that causes upper tract damage. So you need to be cognizant of that, even though it isn't that common. So now we need to get to the sort of the main topic, which is uroflows. Okay, so here's a normal flow, and this was done with the proudP software, which is what I use, and like I've used all of them, or almost all of them, and this one suits me just fine. The main groups that, excuse me, the main data that we get from this is voided volume, which you can see here, maximum flow rate you see here, and average flow rate you have to calculate, and then the voiding time, which is from here to here. So that's what we see. For those that are interested in research, I'm sorry, and there's a shortcut for all this that I think is really neat. I don't know exactly who came up with it, but it's called void, and void with a colon, and then the first is Qmax, that's the maximum flow rate, then the voided volume, and then the residual urine. So that's a neat way of summarizing all this that we use extensively. I put this in because I've agreed to let you guys have a copy of my slides. I'm not going to discuss it, but if you're interested in research, these are some of the other parameters that people look at. Now, Uroflow patterns, in my judgment, are exceedingly important, and that we're just in our infancy in understanding. I'm going to what they mean. I spent a fair amount of time on that. So there's the normal curve, which I just showed you, the plateau shape curve, which is a low volume and a plateau, which we briefly mentioned the differential diagnosis. I'll show you in just a minute. And this staccato portion kind of curve, and then the interrupted curve. And we use those to help us with our differential diagnosis. So if a person has a normal flow curve, okay, the chances of having high flow urethral obstruction is very low, probably 1% or less, but it does occur. It just doesn't occur very commonly. Once you've ruled out obstruction, you look for the whole series of other lower urinary tract symptoms. But one thing to be always aware of is polyuria, and no matter what you think about the logic of it, polyuria can cause all the symptoms of overactive bladder, including urgency. So always beware of that and be aware of that in patients with lower urinary tract symptoms who have normal flows. A plateau curve is either, we'll get this out first, it's either a low bladder or voided volume. And we'll talk about talk about that a little bit later, why that is. But that's one of the most common causes of a low flow, just a low volume. And it's really bladder volume. We'll talk about that a little bit later too. So it's low volume or urethral obstruction or impaired detrusor contractility. And there really isn't much else of a differential diagnosis for that. Staccato pattern is what is an acquired voiding dysfunction. I use it's really just a bad habit. Okay, so and a bad habit can be in reaction to any of these other things, to bladder outlet obstruction, overactive bladder, polyuria, or anything can make the patient aware that they have a problem, and then their brain adjusts to it and tries to modify the way they urinate, and they end up with these awful looking curves. So this patient, but all the data that I'm talking about, when I use these words, they've all had urodynamics to document what's wrong. So this patient has impaired detrusor contractility. The next patient with the with the interrupted stream has prostatic obstruction, but you don't know that until you either get rid of the bad habit or just luck out and pick a treatment and find out that it works, which I think is more common than figuring it out. Flows to be useful have to meet certain criteria. The flow must start and stop at zero. At least one segment of the curve must last at least 2 seconds, because there's no event in micturition that happen quickly. You know, all of the software scans the flow, scans the flow curve at multiple times per second, but there are no events occur multiple times per second, but artifacts do, and I'll show you that in a minute. And ideally, the voided volume should be greater than 150 milliliters, although lots of people say that 100 milliliters is okay. So this is why it has to start and stop with zero. Here's a curve, and you say, well, that looks pretty good. It probably started right here, is what you would say. If you look at the slope of this curve and the slope of this curve, they're kind of similar, except this has more squiggly lines. But look what this one was. This guy had a near normal curve right behind that, and this guy could have too. So that's why that's unacceptable. At least one segment of the curve needs to last at least 2 seconds. Here's 2 seconds, and there's nothing about this curve that's physiologic. This is all artifact or dripping out. I mean, the volume is only 50 milliliters. Now, this is an important slide, and it's an important concept that was first done by my old friend and co-resident Mike Soroki. And we call it the Soroki nomogram, at least everybody does. And it shows that there's a positive but nonlinear relationship between the pre-voided bladder volume and maximum flow rate. So if you look here, if the same person voids with 500 milliliters in their bladder, okay, and they'll get 19 milliliters per second. That same bladder, okay, working at 100 milliliters gets a flow of 8 milliliters. So that's why when you look at these two curves here, these came from the same patient. Okay, this is so this came at the same from the same patient, and this is more representative of what he's capable of doing. I just realized, I don't know, this somehow got cut off here, but this is 15 milliliters per second. So this is an odd shape, but it's a normal curve, and he voided almost half a liter, which is this volume, at 20, probably around 20 milliliters per second. We have to be aware of other artifacts. We already talked about the 2-second rule, and there's something called the WAG artifact. And basically what it is, if urine doesn't hit straight into the water, if it hits something, when it hits, it gets delayed. So it gets to the water slower, and during that part of the stream, there's a fall in pressure, and then when it hits, there's a rise. But this, and it looks like, looking at okay, over here, it looks like that this is that this is a real, but this doesn't last 2 seconds, and it's what's called the WAG artifact. And if you this slide shows this a lot better. So here's a person who if you don't correct for these patterns, his flow, if you just look at if you just look at the readout from the flow meter and you don't look at the tracing, you say, oh, this guy's normal. He's got a flow of 16, almost 17 milliliters per second. But look, his actual flow rate, the last 2 seconds is way down here. It's about 7 milliliters per second. So you'll see later, these artifacts are real, and they're very common, and they cause lots of misdiagnoses and wrong treatments and lack of treatments when lack of workups when workups are necessary. Okay, so here's some studies that we did that we and others have done, and these studies involved a total of almost 3,000 patients, and almost 80,000 Uroflows, and but if you look here, and follow my arrow, because I'm very cognizant, because I'm in the audience as much as you guys are, about how people start. This is a complicated slide, and then they make it more complicated. I really spent a lot of time trying to make this readable. These first 3 columns are a study that we did on only 36 patients. But these are 36 patients that we had complete data on, including urodynamics, office flows, and remote flows. And so you'll see in a minute, I think those are, as we go through the rows. So if you watch the rows, the first important number, I just went through these, the next row shows that of all the patients, 13 to 49%, almost half of patients, had flows that failed quality standards, which the quality standards I just showed you, which means they're not readable. They're not even usable. And so possibly as many as half of patients that are seen, if you don't look at the flow curves, as many as half of them might not be applicable. Now, when you're looking at remote flows, you can compensate it for, because you're not going to have a person that does 50 flows or 1,000 flows and have them all be non-usable. But if you're like most of us, me included, who until very recently just did one flow per patient, they came into the office, they did a flow, and we made a preliminary diagnosis on the basis of that. And that diagnosis, I can tell you, was wrong in probably a minimum of 31 patients. So here's, for example, here's what this number is, and this is our little study of the 36 patients. But of the 36 patients, uh, uh, there was a false positive rate of 31%. That means that 1 out of 3 patients had a flow that was too low. So when they said this person has obstruction, that means that and this is based on the one office flow, okay? That means if the one office flow is too low, because you're going to be diagnosing and treating him for something he doesn't have. That's really important. The next column, the next row rather, says the number of false negatives. That means that's a patient who actually has obstruction, but um, but it was missed because of the artifacts. And in our study, that was 9%. Okay. Then that was based on an uncorrected flow in the office and a corrected flow in the remote flows. So the uncorrected flow made it look like it was normal, but it was corrected when he with the remote flows. Then the next column, these are false positives where they were both corrected, which means, oh, I skipped one. I skipped the most important one. I'm sorry. If we go back up to this one here, this is the corrected maximum flow rate. In the office, okay, the corrected flow rates in remotely it was 21 milliliters per second, and in the office it was 13 milliliters per second. So that's part of the reason we had this 31%, because all of these patients, many of these patients actually had were thought to have obstruction. This is no, excuse me, had obstruction, and that wasn't picked up. So now we come back to the next one. It's the number of false positives where the office flow, the corrected office flow was low, and the remote flow was normal. So the office flow the corrected flow was low, and the remote flow was normal. It means that these people were diagnosed in the office preliminarily as presumptive obstruction. That's 41% of the patients. And the reason is that most, because people come in the office, they're in a hurry to get out, they don't get out, they don't let their bladders fill up, and they just void at low volumes. And at low volumes, they end up having low flows. Okay, and so when they're at home and they urinate, their bladders fill up and it's corrected. So all of this is leading to the main conclusion of this whole talk, is that individual flows are very unreliable, and just need to keep going here. And then this next one is the false negative rate. Fortunately, with zeros, that means that that means what it means. And then finally, the about 5% remotely, but almost half of the patients in the office had, when you corrected their flow rates according to the getting rid of the artifacts and the 2-second rules, half of them had a change in flow of more than 3 milliliters per second, which means when you rely on one flow And I think that would be the same whether it's remote or in the office. If you rely on one flow, but especially in the office, because the people um, because the people don't void normally often because they hurry up and to get out of there. Half the patients have a major change. Three milliliters per second is what the AUA guidelines say is clinically relevant. Okay, having said all that, so what does all this mean? Does this mean this is all that nothing is accurate? Nothing could be further than the truth. The flow meters themselves are reliable and accurate. I showed you the data a minute ago from proudP, but here's I just showed it. But this is from a meta-analysis of the literature. It didn't come up with that many papers because it's a new science here and there aren't that many, but the correlation between Qmax, Q average, voided volume and flow and voided volume and average and Qmax voiding time, voided volume, Q average. The actual correlation coefficients were either very strong or strong, meaning that that the flow meters measure approximately the same thing that the gravitational that the gra that the gravimetric flow meters measure. So it's not that the flow meters are off, it's that the patients are off, okay? And it's that the artifacts are off, and the artifacts are equally dispersed amongst gravimetric techniques and sonoflow techniques. I think all of them, but the real culprit is the patient, because so many of them have a wide disparity of flow rates and patterns. Okay, as I just said, so the Uroflows themselves have tremendous intra-patient variability. I wasn't familiar with these statistics before, very familiar, but the coefficient of variation and the relative standard of error, I'm told that a value above 5 is considered to be very unreliable. And look at these numbers in this was a fairly large study of I think it was 160 patients if my memory serves me properly. Okay. Yet, despite all this, when you pick the best flows, because remember, we can pick and choose. Okay. Remember, so I showed you that one where the fella had, no, I didn't show it to you yet. Well, yeah, I did show it at the very beginning where the patient had, within 3 days, a high flow and a low flow. But so if you pick the best flows, this was the best flow on a patient preoperatively, okay, after, it's a little bit, this was the best flow preoperatively, and this was the best flow postoperatively, 2 or 3 years after a TURP. So it is responsive to change, and I do believe it's a good that flows are a good measure of the efficacy of treatment, but only with respect to improving obstruction. I mean, you can improve obstruction, and all of the symptoms can still be there. So putting this all together, we can say that sono-uroflowmeters are reliable and accurate. Individual flows are unreliable. And there's so much intra-individual variability that in most instances, multiple flows need to be recorded to obtain accurate data. Artifacts and poor quality studies compound this problem even further. And in my opinion, and the opinion of lots of others in the literature, there is no substitute for looking at each Uroflow tracing yourself. And as I said, Uroflows are sensitive to change. So Uroflow monitoring is in its infancy and there's much to learn, but I'm really optimistic that a deep dive into the nuances of remote flow monitoring will lead to highly personalized algorithms that will optimize the diagnostic accuracy and ultimately lead to better treatment efficacy. But with all the artifacts and inconsistencies that we've discussed today, what do you do in your office today, tomorrow, okay, when if you rely on office Uroflows and if you have access to remote flow monitoring? This is all going to be sorted out with good software and possibly with artificial intelligence. But right now, I don't think any of the companies or any have instituted that to the degree where we can be confident. So what are you going to do tomorrow? Well, remember, a single Uroflow, no matter where it is done, has a high likelihood of being inaccurate and could lead to misdiagnoses and wrong treatments. Look at these Uroflow tracings. You'll learn a lot and recognize the artifacts. Look at it, it takes a second or two. You can see every one is of normal shape, and they're over 15 milliliters per second. This guy does not have obstruction with 99% accuracy, and you can tailor your rest of your diagnostic workup based on that near fact. Look at this. Okay, I just looked at it. I scanned it. I don't think it took a second or two at the most to look at that and see that every single flow is certainly well under 10 milliliters per second. Many of them or some of them at least are plateau shaped. There's no question in my mind that this guy has a consistent pattern of low plateau, mostly plateau shaped or nearly plateau shaped curves, and he needs to be worked up with a working diagnosis of either prostatic obstruction or impaired detrusor contractility. For practical purposes, we've ruled out low voided volume by these curves down here, and there's lots of them, and none of them came even near to normal. So you can be confident of that. Now, the other thing you can do, so basically, I think we have these two different kinds of patients, and you can see how long that took. That you can do that yourself. Okay, I do it every day. If you have, I mean, again, I use the proudP, and I haven't used the other dashboards, but this is right from the proudP dashboard. And if you look here, this is the whole month's worth of this particular person. And you can see there's three of these flows here. This is right from the dashboard. There's three of these flows that are over 10 milliliters per second. But I've looked at these, and all of these are artifacts. Remember, the software does not get rid of artifacts. Okay, so now we're going to look at this in a little bit more detail. These are all patients of mine, all had urodynamics, and so I'm confident of the diagnoses. This is a 53-year-old man with refractory overactive bladder. You couldn't ask for a more normal curve. And if you look, here's these are the quartiles. Okay, he has his mean curve, his mean flow looks like it's about 17 milliliters per second, and a quarter of them looks like they're between 18 and 25. You've seen the curves, so this guy is not obstructed. There's the rest of them, and I'm sorry to say that after 4 years of treatments actually the whole 4 years weren't with me, but we don't have a solution for him that he's willing to accept, but we have an accurate diagnosis, and we've ruled out everything that we know how to rule out that could cause overactive bladder. Here's another man, a 39-year-old, believe it or not, never worked up before. had a 25-year history of voiding dysfunction. Look at that flow curve. You can barely see it, okay? And he voided, this is our abbreviation, remember? 3 milliliters per second. He voided 290 milliliters and left 41 milliliters behind. This is another metric that we use called the urge perception score, which means that when he voided this time, he voided because he had a feeling that he needed to urinate, but he could hold for up to an hour, he thought. And then if you look at his curve, his mean is way down here also, about 7. These all of these are artifacts that are above the line, and you can see every one of his curves is a plateau. So there's no question that he had to be worked up, and he was found to have this pinpoint stricture. Amazing that had it, I don't know how long he's had it for, but we did a urethroplasty on him, and I didn't want to make this a show and tell, so we just and that's not what it's about, but he did well. Now here's another person, and this is an unusual 71-year-old man who I've been following for 10 years because of a consistently low office Uroflows, and then for the last year, for the last couple of years, he's been using proudP and has had remote Uroflows. And you can see, but this guy, what's different about him than the others, he had every pattern. These all came from him. May, June, with no interruption. And he's totally asymptomatic, okay? But he has terrible flows, and he has a thickened bladder. And the only reason he ever had cystoscopy, and that's how I got him, is because he had a kidney stone and we did a basket. And so he had to do a cysto at that time, but he's never even, and he did have a large prostate and trilobar, looked like obstruction, but his bladder was not, it was barely trabeculated. So I've been following this guy for years, but I don't know what's going on. But look at this. Look, these are his mean flows. Look, there's nothing even close to 10 in the mean flows. And of these, almost every one is an artifact, but not everyone. So over the course of 2 years, he recorded nearly 6,000 flows, and 3 of them were normal. Okay, so first of all, the chances of a single flow being normal in this man is almost 1 in 1,000. But I ask, and this is the interesting stuff, and this is all thought for research. He had 3 really normal flows. So maybe, maybe it's not a mechanical, it sounds like it's not a mechanical obstruction. And maybe he only has this problem when he's around doctors and doing flows. I don't know. And I'm dead serious. I'm not, so we have to wait and see with that. And just to show you, look at this flow. This one up here was not an artifact. It didn't start and stop with 0, but it did get up to 23 milliliters, but even taking away the artifacts, it's about 19 milliliters per second, and he voided 560 milliliters. So you can see it's all food for thought, and we can learn a lot from this stuff. Now, I wanted to share something with you, which Soundable Health Soundable Health is the parent company. I'm sorry, and proudP. They've been really nice to me. I'm not exactly sure why, and they've allowed me to incorporate their flow into some software that we've developed. Except for we're behind the ball. We haven't done it yet. We're short-staffed, but I want to just share this patient with you. A 62-year-old man came to me for a second opinion about the need for TURP. The first opinion was given by one of the true icons in BPH, whose name I will not say in public, I'll be happy to tell everybody in private. I'm joking. But he was actually scheduled for a TERP, and he came to me for a second opinion, and he showed me this flow curve. That's what he did this in my office. Okay. I had him do proudP, and this is the flow he had. And this is our this is called the lower urinary tract symptom score. Divides into it's a 14 question questionnaire that has 6 different domains, which are a total score avoiding OAB, incontinence, nocturia, and bother. And remember, I said most men with prostatic obstruction also have overactive bladder, and all of his symptoms were overactive bladder symptoms. But nevertheless, he was supposed to have a TERP. Look at his bladder diary. He put out 4,700 milliliters in 24 hours. Okay, voided 17 times a day, and 2 episodes of difficult voids, 2 of urgency, and 1 episode of urgent continence. We treated him with a structured behavior modification program of fluid restriction after modifying, after making sure it was okay to do that. And look at him post treatment. I said red is the most severe symptoms, green are normal symptoms. He was normal in every regard. Okay, his flow had even gotten better, and his diary, he went from 4,700 to 2 liters, from 17 to 11 voids, and was totally asymptomatic, and it had nothing to do with the prostate. And look at the flow he had. And that was the office flow. You have to beware of a single flow. Another patient on self-intermittent catheterization for a year, status post resume, followed by TERP. And then I did another TERP on him. I'm sorry to say, but it was warranted. And he's plagued by voiding dysfunction, and he's bothered a lot. Okay. But if you look here, he's bothered and he had a maximum voided volume of 375 milliliters. And I said to him, and he had terrific flow rates. I'm going to show you. Look at these flows. So here's a month's worth of voids, okay? And if you look here, when he voids between 150 and 200, okay, he has flows that look like this. And when he voids around 300, okay, he has a flow that looks like that. You say, well, that looks really good. What's he complaining about? Because when he has a flow of 840, he's voiding at almost 30 milliliters per second. And that's when he's down here, he's symptomatic. Anybody would be, you say, oh my God, I cured the guy if you look at his flow. And then if you look at his diary, okay, it shows every one of these voids, he voids between 200 and 340, and he gets reasonably good flows but he feels totally bothered by it. He feels like it's incomplete, and he has these interrupted voids and stuff like that. And this I feel like I did not completely empty is just a shortcut for all the voiding symptoms. This is our bladder diary, and it's not possible to list all the symptoms here. So he had weak stream and interrupted stream and the whole thing. And it's all because he's voiding at the wrong volumes. So what we did is, I'm going to go back, we used this as behavior modification for him, and we're still treating him now. So what's crystal clear, and I think you'd all agree, with a flow rate like that, you're not obstructed. You void 840 milliliters, but he also leaves 400 milliliters behind. okay? And he leads, his post-void residual is always high, okay? But he's only comfortable voiding when there's about between 1,000 and 2,000, between 1,000 and 1,200 milliliters in his bladder. That's what he's comfortable at, okay? And if he tries to void with, like I said before, with 300 or less, he's just very uncomfortable and can't void well. And so we've been doing behavior modification, picking volumes at which he's comfortable voiding, and it turns out that they're high volumes. I've recommended a reduction cystoplasty for him, and I think that's the only treatment that's going to possibly help. I'm the world's expert. I've done 20 over 40 years, if that makes you a world's expert, because not many people have done any, and I think it would be very effective for him if he's thinking about it. Okay, so when I say I'm going to end, I'm not really ending now, but I'm getting close to the end because I think I have as many conclusion slides as I have other slides. But just a note on an artificial intelligence, and I'm just going to quote this one study, and in this study, they trained artificial intelligence models were compared to the inter-observer reliability of Uroflow readings by the three researchers whose own reliability was low. So I said, well, I'm thinking, why would you train train artificial intelligence if they're to agree with someone whose variability was high? And other studies have also reported on this problem, that the inter-observer variability at looking at flow tests is not very good. And particularly the degree of agreement in diagnosing bladder outlet obstruction from flows was very poor, with a kappa of 0.2%, of 0.2, excuse me. So we have a long way to go, but for sure, we can train machines to think like men. The question is, will the machines learn to outthink the men and actually get it right? And we have to wait and see about that. So now the takeaway messages, which we're changing up until Anyang who I forgot to thank. Anyang works with proudP, is an employee, and she's been just a savior to me. She's been such a great help in so many ways, and I just want to publicly acknowledge that. But she can attest that we delayed this taping so I could finish my slides. Anyway, so the takeaway message is is that Uroflow is the most important screening test for patients with bladder outlet, suspected bladder outlet obstruction. Almost all men with bladder outlet obstruction have a low flow, but a much smaller percentage of men with low flow have obstruction. And I told you before all the other things that can cause low flow, including low bladder or voided volume. And I really didn't emphasize this much. It's really the bladder volume, that the pre-void volume. So if your residual is low, then your bladder volume and and your voided volume are about the same. But if it's high, then all those numbers I showed you with this Soroki nomogram can be way off. You really have to calculate, add the voided volume and the PVR to use that nomogram. So the second cause is a weak bladder, impaired detrusor contractility, also known as detrusor underactivity. And these acquired voiding dysfunctions characterized by the interrupted and staccato streams, flow curves. And those are, it's really hard to treat those patients. It's hard to get them to change their habits. and most of the treatments end up being empiric without good documentation for whatever we do. So a single office flow, especially one done in an office setting, is an unreliable clinical metric for diagnosing lower urinary tract disorders, such as benign prostatic obstruction. So multiple flows are necessary to achieve optimal diagnostic accuracy. Sonoflowmetry is ideally suited for remote Uroflow monitoring because it can be done in the privacy of the patient's bathroom without any extra equipment. There's lots of other flows, but none of them, except for one, none of them other than Sonoflow are can you void in the natural setting of your own bathroom into the toilet without something between you and the flow machine and the recording. So even there's a couple of pass-through flow meters that urinate through something that you hold in your hand, but even that adds a level of perhaps anxiety and discomfort, perhaps not. I mean, we need to study all these things to see which is best. And so it became done without the hassles and anxiety of office flows as often as the patient or doctor wants. And it serves as a biofeedback tool. And I use Uroflows a lot as biofeedback. I showed you that one patient that we're teaching, but I have patients, I train them to like do Kegel exercises in the middle of a stream, stop it and see if you can stop the stream and make the detrusor contraction go away so that there's separate reflexes. You can stop the stream, okay, but then when you relax, you keep urinating. But if the micturition, if a C fiber mediated reflex is intact, you can, when you stop the stream, it'll stop the detrusor contraction and you'll actually stop urinating. And if you can do that, that becomes a biofeedback tool that can teach people how to, with these voiding dysfunctions to urinate better. Okay. Okay, and multiple studies have confirmed comparable results between Sonoflow and gravimetric flow meters. I'm sorry for all the takeaway messages, but they're all important. There are many artifacts that cause false elevation of maximum flow that are reported by, or it's not most, by every single commercially available flowmeter that I've seen. These artifacts are reported as the flow. None of them have software that says this is an artifact and then smooths out the curve. Failure to look at and critically evaluate the flow tracing, correct artifacts, and evaluate flow patterns results in misdiagnosis in a substantial number of patients. And I showed you the data on that. Failure to correct an artifactually normal flow max due to artifacts may deny an obstructed patient the opportunity for correct diagnosis and treatment. That's a false negative. A person that says that the flow says, oh, you're normal, even though it's an artifact. So the urologist starts sending them to a psychiatrist. There's nothing wrong with you. Your flow is good. Failure to correct low flow due to low voided volume or a non-representative flow pattern may cause a patient without obstruction to get an unnecessary diagnosis of that needs diagnosis and treatment, a false positive, because they're told that they have a weak stream when in fact they don't. An artificial intelligence, I've already told you, I've already said that. Okay, so the promise of pattern recognition, I emphasize a number of times how important the patterns are, but I only touched on it. I'm hoping that artificial intelligence, without our intervention, just setting them loose, setting machine learning and other artificial intelligence techniques to look at these patterns, we may see, they may find lots of patterns that are not apparent to the casual eye. And just like I showed you the patterns that are impactful to us, that I've already shown you, that I utilize the patterns either as behavior modification or for diagnosis. I'm hopeful that artificial intelligence on its very own is going to be able to come up with things like that in the future. So I'm hopeful that your flow patterns and shapes will have specific diagnostic footprints. For example, prostatic obstruction versus urethral stricture or impaired detrusor contractility. Mike Chancellor and I, a long time ago, wrote a paper that carefully looking at Uroflow rates and concluded that there's nothing in a flow rate that we could see that would allow you to distinguish a plateau-shaped low curve that would allow you to distinguish detrusor underactivity from urethral obstruction or prostatic obstruction from a stricture. And I'm very confident that artificial intelligence is going to be able to do that. And well, this is more of a pipe dream than I'm not optimistic about this, but I did some work on this back with another one of those early sonoflow measuring flow right at the urethra with a cuff around it, measuring the flow using sound and vibration. And we thought we were on the road to finding something that would correlate with post-void residual, but we never did, and the company ran out of money, and it's long gone. So, and importantly, AI hopefully will tell us how many flows are necessary for accurate diagnosis. I mean, I showed you one of my patients has 6,000 flows over a decade, but and many have. There's been studies on this that have suggested 25 to 50, but when I showed that same person with the 6,000 flows had 3 normal flows and a really pretty normal looking bladder, despite having all those awful flows. And there might be something in his flows that say, this patient is safe. He doesn't need any treatment, even though he appears to be obstructed. And I hope that AI will tell us what its own hopes are for the future. So that's the end of the lecture.
Thank you, Dr. Blaivas, so much for this very insightful and very comprehensive lecture on the need of uroflowmetry at multiple points of the data points for a better and accurate diagnosis. All right. Okay. Thank you so much, Dr. Jerry Blaivas, for giving us a great lecture today. I would really like to wrap it up here. Again, thank you so much. And then and thank you for your participation for all of those people who have been listening to the webinar. Thank you.